The broadcast is now starting. All attendees are in listen-only mode.
Welcome, EMS research friends, to the June 2018 Pre-Hospital Care Research Forum Journal Club podcast. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. Here with the PCRF Journal Club, we take a closer look at some of the latest research happening in EMS. I'm Megan Corey, and I'm joined by Dr. Bill Toon, Sean Britton, and eventually David Page. We are also joined by study author Ms. Aurora Lay, academic specialist and project coordinator for the Biosafety and Infectious Disease Training Initiative at the Department of Environmental and Occupational Health at Indiana University School of Public Health. The study we will be reviewing today is entitled Determining Training and Education Needs Pertaining to Highly Infectious Disease Preparedness and Response, a gap analysis survey of U.S. emergency medical services practitioners. This was published in the American Journal of Infection Control in 2018. Now, this review is paired with an article written by columnist Dr. Tony Fernandez in EMS World called The Trip Report: Turning Research into Practice. We always encourage listeners to check out this article at emsworld.com. And when you go to emsworld.com, you can go to the menu and go into the category of education and training, and there you can find the trip report, and you can link to other previous trip reports. We also want to remind listeners about the call for abstract submissions for clinical abstracts, and this is a second round deadline of July 31st, 2018. This is for submissions to the EMS World Expo International Scientific Symposium, which will take place this fall in Nashville, Tennessee from October 29th through November 2nd, 2018. Once again, you have until July 31st to submit those clinical abstracts through the PCRF abstract webpage. Thank you all for joining us today. So let's begin. We want to remind listeners that you can use the chat feature on your screen. That should be over at the right-hand side of your screen. You can type in your questions and comments, and we'll bring those into the conversation as we go. So a little bit of background. The Ebola virus disease, or EVD, outbreak 2014 to 2016 really highlighted weaknesses in our EMS preparation and response to highly infectious diseases. Other areas of the healthcare profession mobilized planning and action on developing best practices in medical and public health and community control and prevention and the spread of highly infectious diseases. So the training of EMS responders, we know, can prepare downstream resources and streamline an effective response. Yet EMS providers are commonly overlooked in training and education efforts, and I think that we see this not only in highly infectious diseases. Of course, everybody out there is probably going, yes, yes, in many areas we're commonly overlooked in that training and education efforts that involve a full continuum of care. Maybe this is operational segregation. We can talk about this later. Why do we have this sort of separation that occurs? And the authors bring up a couple of great points as to, why does this occur, and where can we, get better at this kind of integrated interprofessional training. And the training that does exist right now for EMS providers is found to be less than adequate. In fact, the authors point out that looking at the education standards, the initial training and the education standards amounts to 1.3% of the training standards dedicated to infectious diseases. We can talk later too about how they determine that, and what about things that are embedded into skills like body substance isolation precautions and things like that. But they bring up the very good point that OSHA training for EMS providers focuses on bloodborne pathogens and on protection of individuals, but really not on the importance of decontamination prevention and infection control, which is very important in containment, in particular in a highly infective or infectious disease outbreak. So the authors wanted to, and this was their objective, was to explore the extent of highly infectious disease training. And I think Sean will probably get into this, but there's a specific definition for highly infectious disease. And then they wanted to explore the extent of this training and knowledge among EMS practitioners at the leadership, the training, and the frontline level. And at the frontline level, we talk about all 4 levels of provider as well. So stratified by levels of provider: EMR, EMT, advanced EMT, and paramedic. And they really wanted to conduct a gap analysis survey, and this is what they went ahead and did. So Sean, could you take us through, when you go from this sort of objective, how did the authors then go to the methods? What methods did they use in this study?
Absolutely. Thank you, Megan. So this study utilized a survey methodology, and the survey was based off of vetted checklists that were initially used by the European Network of Highly Infectious Disease Units. And the definition of a highly infectious disease that was utilized by this European group was a disease transmission from person to person that causes life-threatening illness and presents a serious hazard in healthcare settings and in the community, requiring specific control measures. And some of the examples included viral hemorrhagic fevers such as Ebola, as well as smallpox, SARS, and other highly pathogenic agents. And so what was done was these checklists were adapted into a 48-question survey, technically 2 48-question surveys. One was for individuals who self-identified as a frontline provider of emergency medical services, and then there was a slightly different version of the survey for individuals who identified themselves as a lead, and that would be a supervisor, manager, director. And based on how the individual self-identified would be which of the 2 versions of the survey they took. Now, these surveys were both vetted through several national associations, including NAEMT, IAEMSC, as well as University of Nebraska Medical Center. And once the wording of the surveys was vetting, it was set out via these different organizations to a total of 108,800 individuals. And then there were 2 follow-up email messages sent over the following 3 weeks in order to get individuals to participate. And this was conducted during July of 2016. And after 30 days, the survey was closed. And so to speak to the response and the findings, I'm passing it off to Bill Toon.
Dr. Toon, are you with us?
I'm here. I just keep myself on mute so you don't hear me groaning and moaning. He got the easy part today. Hold on a second. Sorry about that. So I'll have to ask the author, because I didn't pick up on it when we get her on here, regarding how they selected their population. But there was a total of about 1,500 surveys sent to frontline personnel, and 615 were initiated, and 615 went out to lead level personnel. But their overall response rate was return response rate with answers was 2%. They did this skip pattern of methodology, which varied the response rates anywhere from 16 to 74%, and frontline from 24 to 72. And I believe the skip rate, and again, not as in-depth about survey as I should be, is designed to prevent people from being individually identified or identifying particular individuals. So when they broke down through self-reporting, again, hold on a second, please. What happens when I have milk with my lunch? So when the respondents were asked to identify themselves, self-identify themselves by what position that they held, from the lead level, there was 451 responses, with 12.9% identifying themselves as training or education officers, 53% as high-level administrators, directors, presidents, vice presidents, and then 20% were chiefs. Then with the paramedics, there was, well, then I should say then this, again, self-identification, 14.2% or 14% identified themselves as paramedic, firefighters, and everything. At the frontline level, there was a higher responses. There was 1,100 response, 57% said that they were paramedics, 33% said that they were EMTs, and then the numbers go down because people had a tendency to self-identify themselves in more than one role. So they had multiple roles that they held or identified themselves with in the survey. And I don't find that surprising at all. EMS seems to always have people that carry and wear more than one hat at the time and everything. So the survey went down and continued to break down, which is really good. There's a couple of tables in here, and this always reminds me as I'm looking at this, please actually get the article, regardless of everything that we say today. Be skeptical, get it and read it yourself so you can ask those questions about the actual survey based upon your reading of it. Don't rely totally upon us to answer your questions for. So the survey went on and asked whether their agency provided training on patient and practitioner safety related to infectious disease. Very high response rate, 96% of the leads said yes, and 86% of the frontline personnel said yes, that they receive it. And I think this goes back to what we talk about, that they're used to the standard bloodborne pathogen type training that they have. Now, they were also asked if they've ever been trained on how to screen to know if for a highly infectious disease likely, and they had 86% of the leads and 73% of the frontline responders. And I found that actually surprisingly high, but it could have been with Ebola being so recent when the survey was done in everyone's mind, they may have thought of that as their knowledge. It would have been interesting that this survey was done prior to our Ebola outbreak and everything. And I was, at the time, I was the education training manager for a department that had about 1,200 personnel between career and volunteer personnel, and we were elbow deep into doing a lot of Ebola and trying to get ourselves geared up for the training and stuff in response to what was taking place. So the survey continues to go on and talks about willingness to respond to different levels. You know, if someone was a lead or frontline, would they personnel to encounter a highly infectious disease scenario, what would be their willingness to be either lead or frontline? And very willing was about 21% for the lead personnel and about 40% for the frontline personnel. And I'm not surprised to see a difference there. It's the frontline personnel who actually have to go out and deal with it. It's not the people that sit in the office that would be out dealing with it in that sense of lead. And then they talk about comfort, which I thought was also very good, that they talked about a willingness and comfort. And comfort, really, we see a big change. Very comfortable for lead personnel went down to 8%. And then frontline personnel went down to 20%. Now, if you take the Likert scale that they have here and break it out, which I didn't do overall, you'd be able to see where they fit as being somewhat comfortable and very comfortable, which would be the two that you would do. But once, if you combine those two, for example, for comfort level, you're looking at about 45% for leads, and for frontline personnel, it gets up to about 60% that they begin to feel that way. Then they talk about infectious disease knowledge and resources and training. There's another table within the survey that goes in and breaks down this information for you, so you have a better sense of what type of protective equipment that they have and what people's knowledge of what they begin to carry there. And this asks anywhere from what protocols are in place to what specific procedures, strategies, that there's a amount of shift time that someone is in PPE without changing their PPE, fit testing, agency procedures, a lot of the nitty-gritty detail that gets into the results there and stuff. And you have over here, as you said, right here, that the results right here from the abstract, which talks about how many were surveyed and then how frontline personnel fed about their guidelines, and then also the respondents and stuff. But the article is nicely, has a number of nice tables and a very good explanation of the survey results and everything. So I think that's now time for us to add in our guest.
Yes, you know, Before we bring in Aurora, thanks a lot, Bill and Sean, for describing that. I think it's important that everyone understand that as you're reading something like this too, and I agree with Bill, you pull the article, everyone's going to come from a different, a different stance. So Bill was talking about being somebody who was in the field and who also was part of maybe the preparation, education, and training at his organization. I come from a program director perspective from a paramedic program, and looking at that, the idea that of, it just really rung true for me, that the statement that the authors made about the focus, the OSHA training focus being on bloodborne pathogens, on protection, on the body substance, PPE, that kind of thing, but not really on the importance of emphasizing really the importance of decontamination prevention, and these things that are really important in containment, and that just completely rings true to me. And case in point, cleaning up after lab, cleaning up training. Skill stations, mock ambulances, if you have mock ambulances, not just running scenarios, but actually continuing it into the decontamination practices, not just on a multiple choice test, but actually physically putting that into competencies. That is sorely lacking in our initial training. So I think when you read articles, also everyone's going to have a little bit of a different point of view, which is kind of nice about a journal club, is we all are coming from a different perspective. So different areas and elements of an article will stand out to each of us, and I think that's probably true out there if you're reading articles, and if you're in a group that you have these kind of different perspectives. So I'd like to bring in Aurora, and Aurora Lay is our co-author here, if she can. Aurora, can you introduce yourself, give us a little background about where you're from and what brought you to the being a primary author on this study?
Yes, first of all, I just want to thank all of you for giving such a great overview of the article, and then everybody on the call today for taking the time to read the article. Just one quick clarification on the questions where they're asking about willingness and comfortability between the lead level and the front line. We were more curious about perception. So we asked leads, how willing and comfortable do you think frontline workers are, not themselves? And then we asked the frontline workers how comfortable they personally felt, just to see what discrepancy there might be between the people who are giving orders to certain others to go out and do this work versus those who actually have to do this work. But anyways, so how I got into this research is, initially I was a research assistant at the Nebraska Biocontainment Unit from 2015 to 2016. And that was right after they had received the 3 Ebola patients that they had treated there that were evacuated from West Africa. And then we did about 24 high-risk monitors. So I'm primarily in public health, and our team didn't provide medical care in any way. We did a lot of the decontamination procedures and things pertaining to industrial hygiene and infection control and environmental hazards. And so from there, we became part of one of the National Institute of Environmental Health Sciences worker training program that was born after the Ebola outbreak in 2016, where there were 8 awardees across the nation. One of them is actually UCLA Loesch, to deliver these trainings on highly infectious disease mitigation and management to non-healthcare worker populations. And according to National Institutes of Health, they actually don't deem first responders as healthcare workers. So with me being in public health and with my background being before in community health, I've always been interested in disparities and injustice, not only racially or socioeconomically, but for me, this was a perspective of inequity and disparities on the levels of training, because from our experience at the Nebraska Biocontainment Unit and my experience as the project coordinator of the Biosafety and Infectious Disease Training Initiative, I actually go out throughout the country to try to deliver these trainings to these non-healthcare worker populations, including EMS, firefighting, law enforcement, custodial workers, waste handlers, and even those who work in death care, like mortuary services and so on. So these this was a series of surveys that included EMS, but also funeral homes in another paper, medical waste handlers in another paper, and aircraft rescue and firefighting in another paper, to just try to determine where their needs are, not only to better inform these NIHS-sponsored trainings that we're doing, but also just to get more awareness in the academic community, which often focuses most of their research and funding in hospital settings on like nurses and physicians in terms of infection control, whereas these other populations are equally at high occupational risk, but are often being neglected. So we were hoping to draw some of the attention there, and then also drawing some attention within each industry at an organizational level that might influence some policy changes or some thoughts about curricula structure.
Wow, that's a great background. Thank you for that. First of all, congratulations on this research, and thank you for clarifying that this is a series of surveys and a series of papers that have been published then related to the same topic, but I find it very interesting, non-healthcare workers. So although I did notice that if I've been on the World Health Organization website, not so much the Centers for Disease Control and Prevention, because there's a whole area for EMS providers in terms of injury rates and infection rates mostly it's about occupational health. But of the World Health Organization, I remember I was doing some kind of search somewhere, and I could see, occupation types listed, and especially in, I think, one of the documents on interprofessional training, and their initiative on interprofessional training doesn't include EMS workers. So it includes community health workers and, nurses, doctors, and a number of allied health professionals, but not EMS workers, which I thought was interesting. So which definition, when you said you found the EMS providers, non-healthcare workers, are you talking about the same source, the World Health Organization? Where is this classified? Where were these classifications found?
So these are classifications through the National Institute of Environmental Health Sciences, which is seated under the National Institutes of Health, which is seated under the Department of Health and Human Services. So it's very convoluted, but it's trickled down through there. Okay,
now that's important to know because this is, it's important to first be recognized in the continuum of care in order to, participate in it and be included in many of the efforts to train. So I want to get to a question that I think, Sean, you had earlier about how the sample was selected. So when I do also want to dance into how you developed the survey, but let's talk about the sample selection. So you had an objective, and the objective was to explore, right? And that's when we teach research, we really hone in on a research question. We get students to understand when you develop a research question, then you have to decide how are you going to measure and what are you going to use to measure your research question. And you wanted to explore the existing training and practices in EMS providers, and not just practices, but knowledge. That's another thing. And I don't remember, Bill, if you actually went through that, but the knowledge piece of the survey I thought was very revealing, whether what people knew about. It's one thing to see what they perceived they knew about highly infectious diseases, but when you then go and measure and see what do they actually know about it, there was an incredible disparity there. So I'd like to get at the survey development too, but let's back up and just say, how did you decide on the sample that you wanted to select to survey?
Right. So initially, obviously, with us being here, and the only real working relationship we had with any fire service was Omaha Fire and Rescue, which we've been working with, or the Nebraska Biocontainment had been working with for the last 10 years. But we wanted to get a scope of what was going on in the United States. And unfortunately, since we didn't necessarily have any buy-in with these larger EMS and EMT organizations, quite frankly, a lot of it was just me cold emailing a lot of heads of these organizations saying, hello, we're doing this study. Are you interested in helping us disseminate the survey in return for an authorship? And you know, this is something that I had to go through with the other 3 industries as well that I did surveys on, just us not having any relationship at all at that point. And thankfully, Maniscalco and a couple of individuals at NEAMT said yes. And from there, their email distribution list, including University of Nebraska Medical Center, consisted of over 108,000 individuals. So the links to the survey were blasted out to 108,000 people. And from them, we got the 2% response rate, which sounds really small, which it is, but that 2% of 108,000 led us to over 2,000 responses. But we were trying to do random representative population sampling. So as it was mentioned in the limitations, for some reason, more paramedics answered our survey than are anecdotally nationally represented in the general first responder population. But because this was an unfunded study and being the nature of a pilot and exploratory, we were just so delighted that it was being distributed and that people were willing to offer their information anonymously. But we were just hoping to capture first responders at all levels throughout the United States.
I can speak to that a little. As an active member of the National Association of EMTs, we notice that our membership tends to have a larger proportion of paramedics who enter in as members. So that could explain why there was a higher response rate among paramedics, because the initial survey was being sent to a disproportionately larger amount of them than the true workforce is out there.
So that's a great point, Sean, and that's something out there if you're considering any kind of survey research. Or if you remember last month we looked at a survey research study, I believe, or maybe the month before, and we talked about when you want to see if you are tapping into an equivalent population, you can get statistics from national databases, or the practice analysis I know has some statistics on the breakdown of different demographics of responder types and gender and race and other demographics, responding agency, that kind of thing. And you can compare your results to those national statistics. That'll at least give you, whether or not you have sort of a representative sample that may or may not, fit into something like this. One of the other things, though, that you want to do is consider your research question always. What are you asking, and will that difference in level of provider, are you expecting it to make a difference in the outcome? And if so, then it's more important that you maybe mirror the national database. So that kind of brings to mind a question, and that is, in the surveys that you developed, was there a distinction between and I believe the answer is no to this, because I think you address it in your limitations, whether the responder agency was hospital-based versus other, because I'm really interested in this whole idea that EMS providers are not, included in this really critical training. And I'm wondering if that varies by provider type, if you're a hospital-based service versus a fire-based service or other service, third service.
Right. In regard to that, we actually did not inquire that, just because in the original development of the survey, I used a program called Qualtrics, which is a little bit more complex than SurveyMonkey. But what's wonderful is that when you start populating it with questions, it will give you an estimate of time of how long the survey is for someone to take. So at that point, with the 48 questions, the subject matter experts that were authors on the paper felt that certain questions should be dropped. So that was actually not one of the questions that we included in the survey as part of the data collection.
And were all the respondents from Nebraska? It's a question from Greg, who's typing in a question on our chat screen here.
No, they were not. They were from all over the United States. The thing is that because the answers were collected anonymously, I do as the survey administrator, do have the ability to look at IP addresses, which tell me geographic locations. So there was a pretty even distribution of spread throughout the United States.
Great, thank you. And Bill Toon, I see you're muted, but can you unmute? I think you had a question that you raised during your review of the results.
Well, it's more of a, I wanted to, since you were explaining some things about the survey, the thing that the author shared with me is it's a shame there is this lack of ability to identify our over 800,000 EMS providers through a single organization, registration, or anything that takes the work that they were doing here and made it so challenging for her to have to do individual phone calls. And I continue to think it's a sad state. Yes. For EMS that we're in that thing. The other group, though, I was curious to the author, was there anything done with law enforcement or discussing with law enforcement? Because when I was in my previous role as a training manager, we ended up also doing the infectious control training, particularly with the Ebola thing, and gave them kits and everything. We trained over 800 police officers in the process of taking care of all of the fire and EMS personnel. Did you have any info on that group?
Right, that is a wonderful question. So as part of the worker training program, which I'm the coordinator for, they are one of our target populations. But like everybody else, out of sight, out of mind. So right after the Ebola crises in 14-15, we had a lot of requests from law enforcement to provide this specific training on highly infectious disease mitigation and management, and specifically Ebola. But as a year passed by, and now we are many years removed, obviously time is precious for every organization. So we found that priorities have shifted. So what they're more interested in from me nowadays, especially because I'm located in the upper Midwest, is talking about preventing worker exposure to fentanyl and opioids, which is something we do on the other coin. But in terms of highly infectious disease mitigation and management, law enforcement not only, many are just not interested anymore. And despite us offering this information for free, and we fly nationally, we take care of our own hotel and accommodations, like the cost benefit for them of taking away an hour, even 8 hours for operations level training, it doesn't seem of interest anymore.
I think that's probably an issue that you see across the board in public safety and EMS. Is when you see 1.3% of the initial education spent on infectious diseases as a whole, it does highlight that there's a lot of other training that happens that occurs on a daily basis. However, I would argue, getting back to this, I'm a little obsessed with this idea of the lack of emphasis on decontamination competencies and the incredible role in the prevention of spread of disease. And I mean, you think about it, that probably the dirtiest place ever, the most contaminated place you can find, is the back of an ambulance, or potentially, if again, if proper measures aren't taken. But then that becomes, again, highlighted, and we can all talk about that it's supposed to be, but how much of it is followed through, maybe in practice, but in training, I'm not sure. So that's an important and glaring subject, I think, in this whole paper, even though it's maybe not something specifically measured in the results. It was something that was highlighted in the background that I think stood out. I do want to ask you a question about the survey itself. So when you went to, again, drawing back to that initial question, when you say you want to explore something, sorry, I'm laughing because a comment was made that the front of the ambulance is worse than the back of the ambulance. That's probably true. Don't put your boots on the dashboard. Let's just put it that way. The bottom of boots are probably worse than anything. Yeah, when we get to the survey, when you look at the research question, you're saying you want to explore. Well, that's a big word, and exploring can take so many different directions. It must be really hard to hone in on what exactly you want to look at, because it wasn't just that you were exploring the training. You were looking at the differences, and like you said, you were interested in disparities, but you were looking at not only the differences between the different levels of provider and their responses, but what they thought that the other would respond, if I'm interpreting that correctly.
Yes.
I thought what drew you to do something like that? Because that's sort of a whole other level. What do you think the other person will respond? What do you think your leaders are going to say when we say, you have standard operating procedures and you have good preparation materials and great training? So what does that get at?
Well, yeah. So admittedly, I was very ambitious when I developed this research question, and with most of the authorship there being subject matter experts, and then in the latter half of the authorship was mostly our lab group. They wanted to draw on a survey from the structure of it being closely adapted to those EuroNID checklists I mentioned in the methodology in regard to capacity and capability to encounter highly infectious diseases. But because I do come from a community health and health behavior background, I do strongly believe that in regard to behaviors, and even that is behaviors in terms of infection control behaviors, when you draw upon health behaviors, there's an extent of perceived behavioral control that individuals have, and also perceived norm, and what are the standards, so to speak, or the climate of their organization that's shaping their perceptions around their capabilities to do things. And that was just a question I peppered in there. Realistically, that could be its own study in itself, using a very specific health behavior theory to say, what are the beliefs of X and EMS providers? But that was admittedly me being overly ambitious and putting a lot on my plate because my eyes were really big.
No, I think that I just think you really hit on something that's relevant and important. It gave me some ideas that you could do the same thing between educators and students, and even students that are graduates and are out there practicing, in terms of what they felt they received, what the educator felt they received, and then what they think the other one will say. That's a really interesting level of survey, I thought, so, and added a whole new layer to it. So, Bill, you had.
Sorry. I was just going to say, to add to that, we did the same type of question structure in aircraft rescue and firefighting, and also waste handling, and also funeral homes and crematoriums, and across the board in industries, we all found the same thing: is that generally those in a supervisor, self-identified position perceived their workers to be less willing and comfortable than the workers actually felt. But also just across the board in all four industries, similarities that there are discrepancies going on in regard to standard operating procedures or what resources are available from one level to the next.
And did you, at those other levels, and in those other papers, did you also have a knowledge base section where you asked them about what they knew about certain highly infectious diseases, just like you did in this paper?
Yes. So even in death care, and these are people in funeral homes preparing bodies, about 30% thought Ebola was airborne, and about 10% also thought HIV was airborne.
Wow.
So we found some concerning things there.
Yes. Wow, that's really important. And just a quick question too before I ask Bill to come in here. The other papers that you published that you're referring to, the ones on funeral home directors and other things like, and other levels law enforcement, are these all published in the same journal, American Journal of Infection Control?
So the one on waste handlers is in AJIC as well. The one on death care is on Journal of Occupational and Environmental Hygiene. And then the one on aircraft rescue and firefighting is in disaster preparedness and public health.
Okay.
Yeah.
Same search terms, and this is actually a little education point for our students out there too. If you're interested in looking up these other studies, what would be the best way to link to them? Would they be to search by the same primary author, or search terms if they wanted to look up the results from these other studies?
Yeah, so I'm the primary author on all four. So the best possible keywords for these search terms is probably Lee AB, that's me, and then highly infectious diseases, and then survey.
Great,
And Google
thank you.
Scholar.
David Page has joined us as well, and I know Bill has a question too, so let's battle it out between David and Bill. Let me bring in David first. Sorry,
No,
Bill.
I would like you to, no, please bring David in first.
David, are you on? Let's see. I can see him in the screen. No, I don't see him in the screen, so well, it looks like it's up to you, Bill. You've got the mic. I don't see him in the panelists here.
I'll pay for that. Is your, first of all, but before I forget this, I love the fact that you looked at all of these different professions that would come into contact with a highly infectious disease situation, and it's broadened now my thought that if I end up in a position that I would actually reach out to a larger audience than what we did to make sure that they truly were aware and prepared for something like this. So do you hope, or is there going to be recommendations for any kind of a model curriculum, or is that a next step type thing? Because you touched with the police officers, and I thought you said this very well. There's competing priorities, and right now I know EMS is consumed, and I could be wrong about this, with active shooter training.
Mm-hmm.
And that it would take, an active shooter is certainly much more sexy, to use the term, than is infectious disease. So is there a goal to develop something with a model curriculum for these different professions?
Yes, so what I wish was more well advertised, but isn't, is that as part of the National Institute of Environmental Health Sciences worker training program, this specific one is called Ebola Biosafety and Infectious Diseases. And as I previously mentioned, Biddy is one of the 8 awardees. And so all of our curriculum is on their National Clearinghouse website, available for free. But that is the backbone curriculum. Every training that I deliver, whether it was for Bloomington Fire versus, Monroe Fire Territory, which are both here where I live, but completely different organizations, we do modify the curriculum for every single organization. So what you'll find on the NIHS Clearinghouse website is the backbone curriculum for all the awardees. What we're trying to do now in terms of sustainability is, because initially we were told that this program would be funded from 2016 to 2019 with hope of a 5-year renewal, and that it would be absorbed into the other worker training programs like the one that the HAZMAT and HAZWOPER and Department of Energy. But unfortunately, and I'm used to this because I'm in public health, where you just have to roll with the punches. And unfortunately, because national priorities have shifted away from highly infectious diseases, the funding that we envisioned that would be continued from 2020 to 2024 will most likely not happen. So what we're trying to do right now is create a lot of free webinars online and just courses that people can register for free and watch a 1-hour video with some periodic learning checks, so that this information will live on despite that the program will be over, and that our our cadre of trainers won't physically be around anymore to go and deliver these trainings. So that's what we're at right now. So that's part of the reason why with these papers, what we were hoping is that, and I'm so glad that this paper is getting some more attention, is that some of the national organizations like NAMT and so on might be able to start some of these curricula changes. I don't know if you answered the
Can you hear me now?
Oh, yeah, there we go. There's David. David Page is on, and welcome, David. I hope you've been able to hear some of this great conversation and Aurora's terrific research here.
Yeah, I really want to congratulate her. Fantastic work, and I think that it's a lot harder to do research than people think. And when we have a very candid researcher who can openly say, "Look, this is the best way we could make this happen," and I think there have been some kernels of just some diamonds, that little gems of advice for researchers. People thinking, well, what if I did this kind of research, and how can we get so many people involved so we can get a representative sample? Because we do tend to need our professional associations, like Sean said, and NAMT is a good example of that, to advocate for the safety of our profession. And it's hard to get surveys back, especially surveys that are longer. It's harder for them to create them. So I really appreciate all of the subtlety that Aurora is talking about, and how once we're surveying somebody, we feel like if we could just add a few more questions to really figure this out, it would be much more useful. But overall, an amazing, a very important concept is that it's sort of trust but verify. If you ask some people, of course we've had training, of course we're prepared, of course there's kits in the ambulances. And I was one of the people who had to put those things, especially right after the Ebola thing was going on. I got in and out of Tyvek suits and figured out the duct tape, and really thought, wow, if I make a mistake, I'm dead. And then pretty soon the duct tape, disappears because somebody needed to make a repair, and the Tyvek suits are in the cabinet, and they're just getting kind of dirtier and tossed around every day. So little by little, one thinks, yeah, actually, am I really that prepared? Is it a concept of preparedness, or do I just come to grips with I'm going to walk into dangerous situations and I could die? And then of course there's sort of a fatalistic, I'm just going to die if C. diff doesn't get me, and other bad bugs. I guess it'll be a lifetime of bed bugs and ticks and something else that I pick up. One of my students did a beautiful study trying to figure out what the dirtiest part of the ambulance is, and I wish she had published her results, because she swabbed the backs of ambulances, and I'm sure all of you would love to know that the place where we pick up our bags is actually the dirtiest. So it's actually the mesh on the jump bags, if you're using a canvas bag, and the bottom part of the bag that you set in everybody's homes, that picks up the most bad bugs. Not necessarily the place where we thought, the handles and places where people put their hands was bad, but I do think there's a lot of work to be done to systematize some of these safety measures. And having just been refit for my N95 mask and being told, well, actually, when we do the saccharin test, we're not exactly sure, if that's going to work, but this other test says people are pinching these masks too tightly, and they create a spot for, you know, airborne pathogens to actually enter, even if you are wearing your mask, because you just were trying to wear the mask properly, but you put it on incorrectly. So seriously interesting concepts of how we do this work, and how important it is to do this kind of research, and how low survey returns are, but what researchers have to do in order to, you know, get entire industries to cooperate and point out the problems. So thanks for letting me squeeze in here, Bill. I know you know, it won't be as enlightening as your commentaries about. I can see the message here about yellow canary Dave. Absolutely. Our ambulance service covers the Mall of America and other nice terrorist targets where I just figure, you know, a big cloud of smoke, and who knows what I'm walking into. But in the study that my student did, the straps were on the stretchers go into the washer and dryer. The seat belts do, but it's seldom that we empty an entire response bag and clean the mesh of the bag. So it's sort of an interesting. We know that some places get dirty, so we try and clean them. There are some machines that do this that we looked into at the time, where you can actually cold sterilize, or just but they work overnight. You have to seal the ambulance. The machine you know, does this in operating rooms, and it takes a while for it to occur. And it does use a compound which may or may not be a carcinogen. That's interesting to sort of think we might escape the bad bug, and Ebola won't get us, but then the carcinogen of the cleaning product will get us eventually, because we're around it all the time and we're cleaning these things all the time. So wow, I'm pretty fatalistic. I don't know, Megan. It's a kind of a depressing thought here. Sorry. Ooh, dead silence. Can you still hear me?
Yes.
Okay.
I think everybody's just pondering what you said, Dave.
Oh, it sounds like I hit some nerves, and everybody thought, oh. But let me go back to Aurora saying, you know, doing all of the things you did in order to make this work. You know, using online surveys is a challenge, and getting, you know, co-authors, getting industry to cooperate, and offering co-authorship as a way to entice them to sort of participate is definitely interesting. Do you think you could get a better response, right? So, because it's going to be hard to convince people with a 2% response rate that we've got a representative sample, but do you feel like you could get a fairly accurate response if we were pencil and paper filling some of these out at our mandatory education sessions, for example?
Right. Definitely yes for that. Part of one of the limitations I mentioned in the study is that it was a better step that the survey was distributed by NAMT and these other organizations besides us, Indiana University, directly. But to some extent, that's still like them just distributing it on the outsider's behalf. So there isn't a lot of trust there. So I can understand why the response rate is low. And also, as much as I would love to have funding for this study, part of the reason why we don't pay anybody or provide any incentives is because on a bias level in terms of when you're doing research, especially when you're working with populations where you're not sure of their socioeconomic status, we didn't want to use that as any form of coercion for the study. But in regards to the paper surveys, if somebody were to do a follow-up of that, I think that would be wonderful, because for our training program, at the end of every course, we deliver evaluations. So we get dynamic feedback in terms of like, what did they think of this? And we deliver paper surveys, which then my undergraduate student, who we do pay, then transfers it electronically, because with paper, at least you're getting a 100% return rate, versus if you ask people, hey, after this training or whatever, please go to this link and fill out the survey, the chances of that happening are very, very low.
We have a chat, a message here from Jeff saying that while he agrees there's a lack of emphasis in training as an industry, we have to figure out a way to capitalize on the available time EMS has for training. We're inundated by the need of training in so many topics and levels. We could literally train every day and never have time to run EMS calls. There needs to be a quicker method for teaching infection control. He is talking about teaching the content at a faster pace, maybe using other multiple methods like video and remote learning opportunities, and deliver the material more effectively, better balance of time on task. And I would just add, I think one of our problems is flavor of the month training. It's what's our topic for the month, what's our subject for the time, who's our researchers locally that have this topic, that have the money, that have, something else. And I'd like to propose too that a lot of this is initial training issues, and that's going back to the initial training of EMTs and paramedics, and real competencies on infection control and on decontamination practices, not just paper competencies where people answer multiple choice questions about which is the best material to use and how are you supposed to apply it, and did I answer that one question right in the operations section of my EMT test, but actual practices that are measured in the list of competencies that students perform in a scenario, and that way it's embedded in all aspects, whether you're running a cardiac scenario, respiratory scenario, or infectious disease scenario, rather than keep it so component based. It sounds like there's some baseline competencies that could be embedded in here. So I'm just throwing that out there.
I completely agree with that. And I agree with Jeff as well that for us, our stance on infectious diseases is wrapping it into an all hazards approach. And one of the things that NIEHS is focused on is creating that more dynamic training using specialized technologies. So I do agree with that statement, but at the same time, there are certain things that just can't be substituted for in-person training. I was at a very large EMS service in one of the greater metropolitan areas in the Midwest, looking at their donning and doffing for their specifically dedicated, highly infectious disease responder team, and just finding issues in regards to decontamination, the level of spray they're deciding to use in parts per million in the back of the cab for decon, taping gloves down without pull tabs, and as a result getting tears in Tyvek suits and so on. So for, like you mentioned, the fundamental knowledge that can obviously be taught in a more creative and concerted manner, but I think for certain things, especially PPE, there's no substitute for time on that.
Yeah, and I think what I'm kind of getting at too is we have these two lines that every EMT student learns when they come into paramedic school. I don't know about the rest of you out there, but it drives me crazy, and that is BSI and scene safety. And we hear, and the reason why it drives me crazy is I think it's great that people are saying it, but I really would rather that they do it rather than say it. So when we start running, and now we're in simulation-based training, the era of simulation-based training, so we're simulating more and more and more. And it's no longer acceptable to walk into a simulation and just exonerate yourself of having to check for anything safe on the scene or performing BSI by just simply stating it. And I think a lot of providers and education providers have moved in that direction. Dave, I know, has run a lot of these workshops on running scenarios and validating scenarios and inserting safety issues, open needles, dogs in the background, something where it's not a matter of just walking in and saying BSI and scene safety, therefore now I can begin my assessment according to a checklist. It's actually inserting it in there so that students perform it. And I think the same goes for this wraparound of infection control, and that's the decontamination. Although I would say the bag, that's actually a dilemma, because the bag gets carried into, house after house. The jump bag, what David was raised, that's quite an issue, and how to decontaminate something like that, between calls. That's an interesting dilemma there. So we are getting close to, and actually the end of the podcast. So I wanted to see if Aurora, you had anything to close out, or to any messages for us in terms of what's next steps for you.
Well, next steps for me is I'm working on my doctorate part-time now. So next step for me is obviously to become a more well-versed researcher, and hopefully tapping into larger resources. But with this program unfortunately ending at the end of next summer, trying to integrate these aspects of infection control to existing programs that many worker populations already have to take because of OSHA, such as HAVWOPER. So I'm going to partner with University of Texas and their Utah consortium to try to do some of their trainings integrating an infectious disease lane. But then, just continuing this research with these non-healthcare worker populations. And I thank you all so much for organizing. And I'm sorry, I know I can get chatty Cathy. So if there are any questions that you have, or like you were too shy to speak up, please feel free to email me at able@indiana.edu, or you can just Google me and send me an email.
Well, thank you very much for that. We really enjoyed having you on, and congratulations for your research. Sean, Bill, do you have any final questions or comments?
Just to say thank you very much for conducting this research. It certainly adds to our body of knowledge on the topic. So thank you for your efforts and for being with us here today.
Thank you.
Okay, that was great. Thank you very much for joining us, and thank you all out there for joining us. You can see Aurora's email in the chat screen right now, able@indiana.edu. And if you are interested in sending an idea about a research that you'd like to see us, or even a topic of research that you'd like to see us discuss and review, or maybe you'd like to present some yourself, you can always send an email to David Page. That's dpage@emsed.net. David Page, dpage@emsed.net. Thank you all for joining us, and we will see you next month. Thanks, Jen and Bridget, and thank you, Aurora.
Thanks, great job, everybody.